medium-term, long-term, and moonshot. And what's important about your participation on this upcoming survey is your feedback and input will directly influence the creation and development of what will be our annual Pathways for Progress in PGX report, which will be one way of many ways we'll be able to share with both internally and external communities what it is we're working on, what problems we're solving, and what progress we're making in the field of pharmacogenomics as a whole. So really excited to get that initiative going, be on the lookout for that in the coming weeks and months. Next, we're going to be launching. The Education Committee has been working very hard behind the scenes, and they're close to launching what will be dubbed the Partners in Precision Medicine Educational Content Series. This session format's going to include up to, let's say, 3 speakers, and it's going to focus on bringing into the community some very specific perspectives that are all impacted and influence PGX. Those perspectives will include providers, pharmacists, clinical laboratories, patients, regulators, and an international perspective. These sessions will begin approximately, let's say, maybe at the end of summer or early fall, and we're really excited about all the hard work that everybody behind the scenes has been putting into that. So we're really excited about that. We're actively recruiting speakers. So once we share some more information on that, which I think you may have seen in the newsletter, you can send me or anyone on the Education Committee some ideas or recommendations for speakers on that. And lastly, I'm proud and excited to announce that we have participation from CDER and the Stripe community, or the FDA CDER and the Stripe community. We'd submitted an application many months ago and started a process that will allow them to formally participate. And we now have active representation from both Mike Pakinowski as well as Robert Chuck. So we're pleased to welcome them into the community, and we're excited to work with them and everybody else in the community. With that, I'll pass it back over to you, Sarah.
Sure, great. Thanks, Ben. Up next, we will hear from the community. So we've asked each of the presenting organizations to share updates regarding their activities related to pharmacogenomics, and we're excited to hear from our 4 presenters. And we'll start with Thomas Sparkman. Tom is the Senior Vice President of Government Affairs and Policy at the American Clinical Laboratory Association. ACLA is the national trade association representing leading laboratories that deliver essential diagnostic health information to patients and providers.
Great, thank you, Sarah, and thank you, Ben, for having me, and thank you to the Stripe community, not just for hosting me today, but also for all the work you're doing, particularly in relation to pharmacogenomic testing. In terms of activities at the ACLA, and I'll say at the federal level, we're really gearing up for what we expect to be a substantive conversation about statutory reform of diagnostic oversight. Everyone knows and aware that it's been a pretty big debate for several years, most heated, I would say, since 2014, but it has stretched back almost 30 years now, dating back to the early 90s. Hard to imagine, but it has been a critical debate. And this year we are expecting the reintroduction of the VALID Act. It's been in Congress in some... Thank you. So the VALID Act, we are expecting to be reintroduced potentially around the 4th of July. Is that me?
Let me see if, can you mute your line if you're not speaking?
Okay. So we are expecting the reintroduction of the VALID Act. It's a bipartisan bill that's been under consideration by Congress since 2017.
It's call-in user 7 if you have control over muting.
Yeah, let me see if I'll just have, try and unmute all, and if you want to unmute yourself when you're speaking.
All right, try again. So we're expecting a reintroduction. It's a bipartisan, bicameral bill. The sponsors, Diana DeGette, Larry Bouchon, Richard Burr, and Michael Bennett, have been working on changes. They view this as an active product that they want to actually move through the legislative process. By reintroducing it, they want to kick off that actual legislative process with legislative hearings, et cetera. And this is really going to require substantive engagement from the community if there's chance of it getting it right and having a successful reform. If we start thinking about the post-pandemic era and what we've learned over the past year and a half, especially, we've seen diagnostics in the public eye in a way that no one can recall in recent memories. The importance of having accurate, reliable testing and having robust patient access to that testing is very critical. If you think about the context of pharmacogenomics testing, these tests are making the promise of personalized medicine actually possible. To be able to tell by a person's genes and other markers which drugs would be successful and which drugs might fail. This is hugely important if we're serious about reducing costs and improving patient outcomes. And so it makes having the right balance of oversight for new tests and robust patient access all the more critical. From our standpoint, it's important to make sure we're distinguishing activities between developers and manufacturers and laboratories. This is critical from not just the developer standpoint, but it's also critical from when you think about the agency standpoint and the patient standpoint. From the developer standpoint, we need to know what expectations are out there for development of a new test and also maintaining a healthy test throughout the test's life cycle. From an agency standpoint, we need to know how to appropriately allocate resources so that the agency can be most impactful. We believe that can be achieved through a risk-based system where it's assessed by the actual risk to the patient of an undetected false result for the patient. But then at the end of the day, this is all about patients. We want patients to have access to accurate and reliable clinical laboratory diagnostics, regardless if they're laboratory developed tests or in vitro diagnostic test kits. That needs to be reliable, and we need it to continue to innovate. We need to be able to continue to push the envelope, build on what we've learned, and really expand on what are really powerful technologies and are really changing the patient care continuum. So I would just urge everybody in the community to be on the lookout for this and really take a substantive approach to it. There is an opportunity to bring certainty back to laboratory diagnostic development. We think the VALID Act has potential to be that pathway. It's by no means done. ACLA has certainly not endorsed any product at this point, but it's going to deserve everybody's attention, and it's going to impact pharmacogenomic testing and how this community goes about developing better policy for those tests. So I just want to again thank Sarah and Ben for having me today. I unfortunately got to jump to another call immediately, but really a pleasure, and really, again, thank you for all the work that this community has come together to do.
Thanks, Tom.
Thank you, Tom.
Thank you.
All right, so our next presenter is Teri Klein. Dr. Klein is a co-PI at the Clinical Pharmacogenetics Implementation Consortium. CPIC creates freely available, peer-reviewed, evidence-based gene drug clinical practice guidelines.
Thank you. Okay, so hopefully you guys can see the screen, yeah?
We can.
Great. So I'm actually representing not just CPIC. I'm also the co-PI on Pharm.GKB and the co-PI on PharmCat. So I thought I'd give a brief update on all those things and where we're at. So first off, I think what's most important for this group to know is that Pharm.GKB and CPIC have submitted their formal applications to the FDA for recognition of the human variant database. That process is underway. It has, as all the members on the FDA who are presented on this call know, it has very strict regulations and guidelines that you follow. it's a 90-day process that you can sort of put a time stop in them. Right now it's sitting on their end and they are reviewing, and we are hopeful that we will be able to gain recognition for both of those efforts. I think that that will have a large impact, particularly for the lab testing companies that are coming in with new evidence. So we're excited by that. Another thing that's really is a new collaboration that I think this group should be aware of is we have been working with the ClinGen community. So if you now go to clinicalgenome.org, you can search and find all of the CPIC guidelines. They're linked out, as well as all the Pharm.GKB clinical annotations, particularly the level 1 and level 2, which are important. And the more exciting piece, besides that was exciting, and that's been a long time in coming, is recently I have become the co-PI of one of the ClinGen grants. And so we will be making efforts there to set up a pharmacogenomics working group and formally come up with a process and terminology so that we can truly integrate pharmacogenomics into ClinGen and do a better job in representation in ClinVar. And I think that that's important, particularly as we think about disease genetics and pharmacogenetics. They really are not distinct, and yet for some reason the community has put them into two separate buckets. And the most obvious place of that has been, if you look at the secondary findings committee from ACMG, paper was just published a couple of weeks ago. It's a very watered down statement having to do with PGX. It's been a fight to get PGX into ClinGen and ClinVar, and I think it's important that we move in that direction. So I think that that's a big win for us. Just for people who don't know, here are the URLs for each of these projects. PharmCat is the pharmacogenomics clinical annotation tool. It uses Pharm.GKB and particularly the CPIC guidelines and spits out, and I'll get to it in a second, those results. So that's exciting. With regards to Pharm.GKB, I just want to provide easy access and remind people that there is a blog. Last week, NHGRI sponsored the Genomics Education Week, and I want to give a lot of kudos actually to Phil, who's on this call, who spent a lot of time as well as others developing this. But if you go to the blog here on Pharm.GKB, and it not only does it capture all the Twitter conversations, but it's an excellent compendium of all the resources and of all the individuals who are, or a lot of individuals who are involved in the PGX community, really point out some excellent resources, papers, etc. And so I encourage you to look at that. I also encourage you to look at Pharm.GKB and CPIC, but that's a different story. I want people to understand that Pharm.GKB has changed their levels of evidence. This becomes important for the strike community. It's rather than being a qualitative assessment, it is now, there's a quantitative algorithm. We describe it briefly on the blog, but there is a CPT journal that's going to be coming out in September that is totally focused on pharmacogenomics, and it's in that issue that you can find the complete details with regards to those annotations. And this is important for anyone who is doing implementation, because the level 1 and level 2 are often accepted as valid, similar to the CPIC guidelines. So I encourage you to look there. Just as a brief update for the CPIC guidelines that are in progress. Again, you can always go to the CPIC website to get all the guidelines, but this is just a brief summary of what the CPIC group is currently working on in terms of guidelines. As you can see, there's many going on, requires a lot of effort. As a reminder, the CPIC is an open organization. If you haven't belonged, I encourage people to belong. And lastly, there's a general call the first Thursday of every month at 8 a.m. Pacific time. And lastly, the pharmacogenomics clinical annotation tool has been in development for a bit. It was recently funded in the past year by NHGRI, and it is about to undergo its formal release probably in the next month or two. And I encourage people who are doing implementation again. It's a standard way of being able to put in a VCF file, whether you're using whole genome sequencing, exome genome sequencing, or even just a panel. And it's a way of putting things in and either getting out the diplotypes if that's all you want, or, for example, the CPIC guidelines. Ultimately, we'll also have the Pharm.GKB clinical annotations 1 and 2, but we're getting along those lines. Important factor for PharmCat that I'd like this group to be aware of what's coming probably within the next year or so is batch production with PharmCat, which I think is important, and also integration with EHRs. So we're hoping to be able to provide those tools. And that's the update from PharmCat, CPIC, and Pharm.GKB.
Awesome. Thank you, Teri.
Yep.
All right.
And if I can figure out how to unshare, I'll stop. Maybe you know how to do that.
Sure.
Oh, stop sharing. There we go.
All right. Up next, we have Cynthia Benz. Cynthia is the Senior Vice President of Public Policy at the Personalized Medicine Coalition, the PMC representing innovators, scientists, patients, providers, and payers, promotes the understanding and adoption of personalized medicine concepts, services, and products to benefit patients and health systems.
Great. Hi, everyone. And thanks so much to Sarah and Ben for asking me to speak about PMC and our work in pharmacogenomics for a few minutes. As Sarah mentioned, we're a multi-stakeholder coalition. We were started about 17 years ago. We actually have 220 members now that span the healthcare spectrum. And in addition to the constituencies that Sarah mentioned, some of the largest sectors of our membership is actually research and clinical care institutions and patient advocacy organizations. Our collective goal is really to advance the field of personalized medicine through 3 different ways, through public policy, science policy, and through general education. As Sarah mentioned, I lead the public policy work for PMC. And we're really a bottom-up organization where we work with our membership to define our annual public policy portfolio. And our main goals are to cultivate a friendlier landscape for personalized medicine on Capitol Hill and within the various federal agencies like the FDA and others who have some hand in the development, oversight, regulation, reimbursement, or the use of personalized medicine products and services. As you can imagine, it's a very large portfolio. Our current policy agenda has 45 different issue areas we work on. Pharmacogenomics really rose to the top of our public policy work in 2018. That's when the FDA started focusing on the clinical validity of some of the drug-gene interactions that were being reported by some pharmacogenomic tests. And FDA was really becoming concerned that some of the biomarkers were being mischaracterized in their view without evidence in ways that were calling into question the safe use of drugs. And then subsequently, many of you know they started notifying labs to take action related to some claims they were making. It was soon after that that PMC met with the agency in order to better understand what their concerns were. And ultimately, we became involved with the Stripe collaborative community because in that meeting we had with them in 2019, they expressed to us that the community was not organically growing together to find solutions to address some of the concerns that they were identifying, and that the collaborative community was a helpful model in other areas where the community could come together to address collective concerns. So we actually serve on the steering committee of Stripe. I'm PMC's representative there. And we're really looking forward to helping Stripe shape their strategic plan. Once we get to that point, we've made a lot of great progress, I think, through Ben and Sarah's leadership and others on the steering committee and standing up relevant subcommittees that are going to help move things forward. We're also represented on various Stripe subcommittees by my colleague, Dr. Daryl Pritchard, who's also on the line today. Daryl's the Personalized Medicine Coalition Senior Vice President of Science Policy. Among the many hats that Daryl wears, he leads our pharmacogenomics working group. Since FDA's actions a few years ago, where they were flagging some of the commercial claims of PGX drug-gene interactions, one of the challenges that we saw was that there was confusion that was happening around the appropriate PGX testing and authoritative sources that should be guiding their use. And really, that was one of the leading barriers that we saw to hampering the field at the time in using PGX in clinical care. So under Daryl's direction, we established a pharmacogenomics working group, and they've been conducting an analysis of FDA's table of pharmacogenomics associations and comparing that with what's reflected in current PGX guidelines from CPIC. And we heard a wonderful update from Teri on all the wonderful work that CPIC's doing with others in the community. The analysis from this group's, we believe, going to allow for a better understanding of what's both reflected in FDA's table and in the evolving clinical guidelines, and really help to tailor PGX strategies that's based on the scientific knowledge of what drug-gene interactions are really occurring and what the evidence base for that really is. So the analysis is complete. With the help of many of you on the line, a report's being developed for submission to a peer-reviewed journal for publication. And really, we do think that this is a missing piece, and we believe that's going to be valuable to alleviate some of the confusion that's in the space once this report is ultimately published. In addition to our involvement in Stripe and also our work in science policy to expand the PGX evidence base, we advocate for issues in public policy to support the personalized medicine field. I know on one of the previous Stripe community calls, you heard about an effort to develop legislation on pharmacogenomics that could potentially be introduced through the Congressional Personalized Medicine Caucus later this year. PMC actually established that caucus, and we've been working to grow it. We just actually added 4 new members to the roster for the Congressional Personalized Medicine Caucus in the last few weeks. And the leadership of the caucus really does reach out to PMC for our counsel on what's most beneficial to the personalized medicine field. They tend to get approached by either individual members or organizations of PMC, and they look to PMC to be a trusted voice in what's ultimately going to raise all boats for the personalized medicine community. And so we're fortunate to play that role. In addition to what we're doing specifically on pharmacogenomics, we also conduct Hill advocacy to strengthen and support FDA's workforce. This is something that other groups in the PM space don't typically get engaged in, but we sit on the board of an organization called the Alliance for a Stronger FDA, which is very focused on making sure that there's a balance between funding that goes to the agency through user fee that support industry activities with general budget authority appropriations that really do make sure that FDA has a well-supported and trained and responsive workforce that can meet all of our needs. And we're just so thankful to the FDA representatives for participating in this collaborative community. And we know a lot of what they do and their involvement in this is supported through appropriations. So we're doing our best to make sure that you get what you need. And then finally, I know Tom spoke quite a bit about the VALID Act and diagnostics reform. We've been engaged in monthly stakeholder conversations around the FDA user fee reauthorization and why that's important. That program expires in September of 2020, and it needs to be enacted through legislation. And many have talked about the user fee reauthorization being the ultimate vehicle that helps to move some of the diagnostic reform pieces of VALID. So we're heavily engaged in that. And then the last thing I'll mention, Sarah said to bring up some relevant current events. PMC has our annual conference in November every year. We are going to be doing that in person, November 18th and 19th. We're going to be formalizing our new location and announcing that soon. But the reason I bring it up is we will have a focus on pharmacogenomics at the conference, and there will be at least one panel that talks specifically about PGX issues. So we hope you can join us for that. And if you have any questions, you can feel free to reach out to me or Daryl. Both of our email addresses are just cbenz@personalizedmedicinecoalition.org or dpritchard@personalizedmedicinecoalition.org. And with that, I'll turn it back over to Sarah. So much.
Great, awesome. Thank you so much, Cynthia. Really appreciate your updates. Let's see. Okay, we'll now hear from Jill Bates. Dr. Bates is the Pharmacogenomic Testing for Veterans Program Manager at the Department of Veterans Affairs. PHASER is a new program offering genetic testing for veterans to inform decisions about their medications.
Thank you so much. I hope all you can hear me okay and you can see my slides okay. So I'll go ahead and put them into presentation mode. And first I want to start out by saying thank you for inviting me to speak to all of you about the PHASER program. I'm really excited to introduce it to this group and tell you a little bit about what we've been up with at the Department of Veterans Affairs. And so PHASER is an acronym. We like our acronyms, and it stands for Pharmacogenomics Testing for Veterans. And it is a partnership between the VA and Sanford Health. And this partnership was established and the program was launched out of Durham, North Carolina in 2019. It is funded by a $50 million donation from Sanford Health to the Department of Veterans Affairs. And what the PHASER program will provide is pharmacogenomic testing to veterans nationwide, up to 250,000 veterans through the year 2023. And so we're really excited to be able to offer that to our veterans free of charge to them and the taxpayer. Once enacted, it will be the largest, most effective and integrated pharmacogenomic program in the United States. And so we're really excited about that, and we hope that PHASER proves to be a leader in this space. As I mentioned, PHASER leadership and operations are housed in Durham, North Carolina, within the Durham VA Medical Center. And the program itself falls under the National Oncology Program within the Department of Veterans Affairs. And so I just want to explain a little bit about the implementation of PHASER and how it's working. So right now we have 12 sites that are live. Our goal is to develop anywhere between 40 to 50 what we're calling PHASER Centers of Excellence. And these are VA facilities throughout the country that will set up PHASER at their site and will have local expertise available to facilitate integration of pharmacogenomics within the care for veterans. And so the goals of this local team, which includes a clinician leader as site champion, a pharmacist leader as pharmacy site champion, and then a site coordinator, which functions as like a project manager to support both the site champion and the pharmacy site champion. The goals of this local team is to lead the education, outreach, and uptake of pharmacogenomics testing locally, to communicate with facility leadership and the National Project Office for PHASER, which again is located here in Durham. This leadership team at the local facility serves as the primary local point of contact for PHASER, for anything PHASER related at that facility, and they chair the local facility PHASER steering committee. And so we're really excited. Let me see, I'm going to stop sharing here. So we are really excited, and I would say we have it described in different ways. And so we have, as I mentioned, 12 sites live, and we have about 12 sites in which we are what I would call engaged. So that means we have signed agreements with them to bring Phaser to their facility, and we are in various stages of implementation with those sites. We have several other sites that we are also what we're calling affectionately going steady with or dating, where we are discussing bringing Phaser to their institution and working through all the logistics to see if it is right for the care for their veterans. And so we are really, truly excited. We are seeing a lot of things with Phaser. We are at nearly 5,000 orders to date since its launch. And so just really excited for everything that it can do to improve the care of veterans and for everything that we will learn as a result of this project. And so I want to thank you for giving me a few minutes here to introduce Phaser to you. There is a public-facing website if you're interested in more information. And you can always feel free to email me as well, jill.bates@va.gov. I'm happy to respond, and thank you so much.
Wonderful, thank you. Very informative, and hats off to each of you for tremendous efforts across the board. Up next, we'll hear from the committees, but first we want to congratulate the inaugural leadership for each of the first 3 STRIPE committees. Study designs will be led by Jay Patel, Brenda Teeple, and Daniel Hertz. Consensus development will be led by Gwen McMillin, Allison Quinn, and Carrie Hoffer. And evidentiary standards will be led by Nita Limdy and Bronwyn Ramey. So thank you to everyone who applied to participate. Right now, we're working on completing the committee slates, and we're looking at late July or early August to officially launch the committees, and new committee development will be following shortly thereafter. And the leadership teams, as been mentioned, have been working behind the scenes to coordinate these efforts. So I'll turn it over to the teams here to share updates on progress, and we'll start with our study design task force.
Thanks, Sarah. Hey, everyone. This is Jay Patel here. Again, I serve as chair of the study design task force and currently work at Levine Cancer Institute, part of Atrium Health in Charlotte, North Carolina, where I lead our pharmacogenomic research program as well as implementation. So we've been working extensively with, as you saw, Brenda Teeple, who is Chief Clinical Officer and Director of Regulatory Affairs at Arbit Consulting, as well as Dan Hertz, who's an assistant professor at University of Michigan College of Pharmacy. And so we've been working to put together our committee charges and objectives here. And generally speaking, the purpose of this study design task force is to really provide some high-level recommendations, tools, resources, and guidelines on pharmacogenomic study methods, with really a goal to improve and optimize the effectiveness of pharmacogenomic studies on the regulatory and clinical utility landscape. And so we're really focused on identifying those key elements needed in study design, methods, and research to really answer specific clinical, regulatory, and/or cost objectives. And so again, we've more or less finalized our committee charge here. And we've now created 3 subcommittees within the task force to really narrow the scope of work here for these key objectives. Again, including regulatory, reimbursement cost, as well as clinical utility. And so we're actively reviewing applications and conducting outreach for additional expertise within these subcommittees. We've already identified several individuals that we've been reaching out to. And if you're interested or may know of anybody who may have experience or expertise in clinical trial design for biomarker development, biomarker guided therapies, identifying standards for showing benefit of preemptive testing, et cetera, drug development of LDTs, reimbursement, diagnostic tests, please do connect with us. Feel free to reach out or refer them to us. And then lastly, we've also submitted a proposal to the ASCPT 2022 annual meeting as a roundtable discussion. And briefly, what we'd like to do here is really describe some of the key objectives and initiatives within STRIPE more broadly, including updates from Sarah, as well as representation from FDA and within the study design task force, then followed by an interactive roundtable discussion with a broad group of stakeholders to really discuss questions, concerns, thoughts, viewpoints on pharmacogenomics across the industry, regulatory landscape, research, clinical settings, laboratories, and payer communities. So we think this will really make a nice kind of diverse conversation. And then again, we're looking to have our launch meeting sort of late July, early August. So more to come on that exact date. I think Renda and Dan, I believe, are both on the call here. Feel free to chime in if there's anything else that I've missed here.
All right, great. Thanks so much, Jay, for the updates. And let's go ahead if Bronwyn is here, if you have any updates on evidentiary standards.
Hi, everybody. Nita is out of the country, so I'm speaking for the both of us today. Nita and I have been working on building out our team as well for the evidentiary
Smart.
subcommittee. We are going to be looking, well, we've developed about 4 main things that we want to focus on. And one of them is, of course, synthesizing all of the stakeholder perspectives, recognizing that academia and industry laboratories, which is where she and I hail from, are not the end-all be-all and only perspectives. So we are working on gathering a broad host of perspectives to align ourselves on what we all believe are generally accepted standards and definitions and nomenclature and how we evaluate scientific evidence, because everybody has their own method, and we'd like to find a way that we can come up with a sort of a best practices that people can at least start with as a baseline. So as an output of that, I think we have a lot of work product that's planned. It's going to be pretty busy, so we hope folks who join our committee will be ready to type and work and write and think. One of the things we're going to work on is a framework for identifying biomarkers for inclusion. So we recognize that there are already committees working on and publishing minimum content standards, but we want to work on also focusing on analytical validation standards, recognizing that, for instance, there are proposed standards and guidelines and FDA standards and guidelines for NGS validations, for instance, but that's a method, not an approach to the science. And so we would like to create analytical validation standards for PGX testing, regardless of methodology used, and similar standards for interpretation, how we approach the interpretation of pharmacogenetic test results, so everybody can have an understanding of what's going into the process, what our inputs are, and standardizing that. We're also looking at how we can develop incentives for implementers to submit their information and to subscribe to these standards. How can we influence folks to buy in to these standards that we're planning to create, so that everybody in the market who would be shopping for PGX testing would have some sort of standard, a label of some sort, to recognize that at least all the providers that they might be looking at have at least subscribed to this standard, and they have a sense of the quality, a baseline's quality. We've also been talking about health technology assessment practices. So this is something that Ben has mentioned, that it started here and wound up jumping over the pond to Europe, and we'd like to bring it back because it's a great way to assess a technology. You know, what is a good framework to know whether what I'm looking at is quality or not? Is it something that I can trust or not? And so we're working on finding resources to help us bring that facet into our work. So as you know, as mentioned before, if you know somebody who likes this kind of thing and likes to work and write, because again, we are going to be writing a lot, send them our way.
Great. Thanks so much, Bronwyn. And let's see, let's hear from consensus development. If you have anything to share, Dr. McMillin.
Yeah, so we just met for the first time really last week, Teri and Allison and I with Ben and Sarah, and our overall charge is to establish and architect methodologies for enhancing consensus-based recommendations. So we are also looking to kick off in August and are looking for anyone that's interested in helping us participate in terms of developing this program.
All right, great. Thank you so much. We'll shift over into the open forum discussion portion of the meeting. So at this time, if anyone has any questions, if you'd like to bring up a new topic for discussion, you can feel free to come off mute and take the floor. So we'll open it up.
Hi, how are you? This is Ramey, Chief Medical Officer of IGX, or Innovative Genomics. Sarah, thank you very much for inviting me to the meeting. As you are aware, I was going to bring the topic that hopefully you guys are aware of, the proposed changes for Novitas PGX local coverage determination. I don't know, sorry that I joined a little bit late, but I got caught up in another meeting. I don't know if you guys already talked about it, but this is something that could, in essence, change the access of pharmacogenomic testing and being covered by this large MAC in many different areas in the United States, many different states, which is basically what we're trying to do, right? To facilitate the clinically useful and safe approach to pharmacogenomics implementation. And this is the MAC that was slacking way behind in the type of coverage to a point that it was almost dangerous to not to cover for some patients. In compared to the other MAC, MolDX, who had an extraordinary coverage, including at least the FDA Table of Associations and CPIC guidelines. The proposed Novitas covers the FDA table, the biomarkers, as well as I think it's typically A and B, which is a little bit further, but still within the safe parameters, I would say. I don't know if you guys have had the chance to review the bill, but we have until tomorrow to make input if there's any proposed changes, adjustments, and especially the way that the billing of those should be done. And remember that for CMS, the way your MAC, you've billed your MAC is the way that you should build your commercial insurance. So we need to make sure that whoever is in that territory, we try to get the best coverage for our patients. Was that already being brought up or not yet, Sarah?
Nope, all you.
Sorry.
Feel free to add anything. Yeah. It's great. Let's see, and when did you say are the deadlines to submit the comments?
Tomorrow.
Oh, it's tomorrow on the 15th.
Yeah. They don't give you, they just release it on Thursday, so they don't give you exactly much notice. They don't want you to see it.
Yeah, any interest in organizing, Ruben, maybe a small group call this afternoon to discuss additional comments or submissions for anyone that's interested? And I guess if anyone is interested in kind of talking a little bit more about this, just let us know in the chat or maybe email Ruben as well. We can, I think it's a great point to talk about the open comments right now for the Novitas coverage.
I'd be happy to join a conversation. Annette.
Annette, how are you?
Great.
I mean, everything that we do is basically pointless if there's no coverage by CMS, unless you have somebody paying for their own test or the commercial insurance. So, I mean, it ultimately comes down to that, whether it's a health organization, university, or private organization, it's the same. The content could be amazing, safe, clinically useful, but if nobody's paying for it, it's just not going to happen for anybody.
Yeah, I think I want to be involved in that conversation too. I'm working with a lot of major employers on this.
Okay.
So please include me in the invite.
Sure.
Later today.
Send out an email after this meeting.
Okay, thank you.
And Ruben, can you clarify? I think we had a comment that the comment period ends on the 24th. Is that the deadline to submit comments on the 24th, or is that the day they're reviewing the comments?
I think that's the day that the meeting is, the 24th.
Okay.
The public meeting to attend and review all the comments, and then for them to take note and take it back to whether they need to change anything, and then go through the approval process.
Hi, this
I mean,
is
it's a
Max Smith. The meeting is on June 25th at 10 a.m. Eastern Time.
There you go.
And the comment period closes on July 24th.
Okay,
that's located at the bottom of the proposed LCD.
Beautiful. Yeah.
Okay, so a little bit more time.
Yeah, beautiful. It's a very, very extensive bill. I mean, it's put together like if it was going to be in place. We just need to make sure that aligns with everything that we do, especially the billing fashion. That's what we need to see, the modality on which the CPT codes that are included based on what the content of each assay is are allowed to be billed. That's the part of the coverage itself. It's beautiful. I think it will benefit a lot of patients.
Yeah, the problem is so many of the patients that we're concerned about are on multiple things. And if they are going to break it up into panels or this test for this, when you add it up, it's way too much money as opposed to doing the whole thing at once.
Exactly. That's the billing modality that we need to, the coverage. It's literally the way it's supposed to be. It's the billing modality that we need to make sure that it's addressed correctly. And, you know, I guess I was telling Sarah in a previous conversation that it's clear that pharmacogenomics and many other genetic testing should be done as a panel rather than one gene, one drug. That to me, it's clinically useless and almost a disservice to the patient, as there is impact in other medications that other providers of the same patient may be using the patient. So
exactly.
And the bill does say something along those lines. We just need to make sure that it's clear and not like any government document that they leave it up to everybody's interpretation, and then, you know, little by little end up causing trouble. So I think we have a good opportunity here to make sure that it's clear.
Yeah. It'd be nice if it also made sense.
We'll organize a call for everybody in the community that wants to join, and everybody that's available to be able to jump in and feel involved. That's really what the community's about. So thanks to Ruben for bringing this up, and we'll work on circulating what that options are for setting up that call, and then we'll make it happen.
Is there any part of the community that is in charge of reviewing, going over this type of documents, pointing out things? I mean, we know exactly how this should be done, and it's not about anybody's benefit. It's about the patient's benefit. We have to be 100% patient-centric, and in order to be able to do that, we need to have the tools to help the patients with what we do. So, is there any part of the community that it's their task is to review these documents whenever they come out? I mean, something like this for Novitas, it hasn't happened in the last 10 years. It's about time that it happened, and I think, you know, making sure that we do this together and both count, individual comments as well as community and consensus comments count. Is there any part of the organization that takes care of these things?
So this is a great opportunity to highlight not only the work that the Consensus Development Committee will be doing and being able to organize, you know, and bring together what all stakeholders' viewpoints are in a way that the community is speaking or stating its stance, as well as, you know, like evidentiary standards that takes part in reviewing evidence like this. So there's actually a nice overlap between multiple subcommittees that were talked about today. And while we may be at the very early stages kicking that off, it doesn't mean that, I mean, what an awesome opportunity to be able to utilize the infrastructure that we built to be able to, you know, take action and move forward. So at least at a minimum, just those two, Ruben, right there. Yep.
Yeah, it seems like there's a lot of interest on this working call specifically to discuss Novitas. So perhaps we can also discuss during that call structuring something like that and what gauge people's interest in participating and how it would be kind of best to review these types of documents as they come up. So that's a great point. All right, great.
I want to also ask if we have intention or have a group of people who are working on patient communication. One of the things that really troubled me in the past is that there seems to be a lack of respect for patients' intelligence and what they quote should and shouldn't be able to know. And so I just want to make sure, especially for patient advocacy groups, every major employer has a dozen different vendors. There's a vendor who's a specialty advocate in mental health, another one who's specialty advocate in diabetes, another one, you know, cardiac, et cetera. And I want to make sure that we have tools for those people who are directing and coordinating care for patients who aren't clinicians. They're patient advocates, and these are deeply entrenched for the last 20, some of them going back 20 years in the whole, you know, ecosystem of at least employee benefits. And we want to make sure that their, you know, their needs are being included, and not just physicians at the health center. From lots of patient experiences and research that we've done, is you have patients with multi-conditions in the hospital being looked at by somebody who doesn't understand anything about their other two conditions, and delivering care that completely compromises something else that's important. And I've had personal experience with that in the last 3 weeks. My husband was in the hospital, and I had my tools, I had my app, and I was able to prevent two major things. So I just want to make sure that we're not letting the FDA and an overconscious abundance of assuming everyone's not capable of having an opinion about their own care, that they have consumer tools that are available to them as well.
Kathy, thanks for your comment. And at the very beginning of Stripe, we'd set out with a vision to you know, like activate or stand up at least 8 or 9 different pathways for participation. One of those pathways being patient advocacy, access, and equity. And as you saw today, we've just now activated these 3. So it's definitely on the horizon. I'd be happy to talk with you and anybody else offline on if we want to maybe move that timeline up on standing that type of committee. I'd be happy to talk to you about what that might look like. But definitely have plans to do that. And we're working towards that. So yes.
Yeah, I think it's really important sooner rather than later, because I'm seeing some indication that there's just an assumption that this is, you know, not for consumers.
Let's talk about it.
Okay, thanks.
Yeah, that's great.
Hi, I just wanted to chime in. This is Allison Quinn from the Consensus Development Group. That we were talking also about really wanting to include the patient perspective in the consensus, you know, in the, you know, kind of a community that we're going to be trying to develop the consensus from. So I just wanted to let you know that as well. If you, you know, would like to work with us or have other people who you'd want to make sure that we reach out to, you know, please let us know.
Yeah, well, yes, I think that's really important. Thank you.
Thank you. All right, any last questions or comments before we close it up?
Okay. Well, thank each and every one of you for joining us this morning. Thank you for participating in Stripe. Thank you for your passion for PGX. We'll be organizing that working call on the LCD. Thanks to Ruben for bringing that up. And thanks again. If at any point in time there's something that you believe is not being addressed or that you'd like to be addressed, please reach out to Sarah or I or the Stripe admin. And we'd be happy to talk with you on being able to make sure that does get addressed. So thank you very much. Hope each of you has a great rest of your week. For those of you on vacation that are joining us today, thanks. That's awesome. And for everybody else, we'll talk to you soon. Thanks.
Thank you,
everybody.
Have a great week.
Thank you.
Thank you very much.